right. The first thing I do want to say is that I have no financial disclosures in this particular situation, which is particularly relevant because, we are talking about, I'm going to be talking about a specific product, but I'm not being paid by them. It's not an endorsement of a specific product because there are many out there and each have their pluses and minuses. All right, so also notable, this is a big picture lecture. I'm really kind of taking a general view. I could easily get up here and talk for a full day, but we're not going to do that. I'm going to try to stay within the time constraints. But certainly, smaller picture discussion or further references are available. All right, so what is pharmacogenomics? Basically, it's the use of the knowledge of a patient's specific genetic makeup, either large discrete genes or these single nucleotide polymorphisms, to make more informed choices in medication selection and to help individualize treatment. If you take nothing away from this talk today except for this piece, I want it to be this. None of these things are useful outside or without using your clinical judgment. This is one tool in the box. It's something that helps us kind of guide medication selection, but you know your patient better than any lab test ever will. So you have to put this in the context of your own clinical judgment and your own patient factors. As one of my colleagues likes to say, genes, we all have them. And obviously we don't all have the same version because, of course, on an evolutionary level, genetic diversity is crucial to adaptation and crucial to survival of the species, right? So large mutations can cause large changes. And I know this is a little bit basic for our audience, but I want to make sure everybody's kind of on the same page. So small mutations, though, can be more variable, and that's where we come in with this SNP, or single nucleotide polymorphism, which is, of course, I got through that a little too fast. Of course, a mutation in a gene that is just a single base pair, right? So why do they matter? Often they don't. A lot of these SNPs, a lot of these mutations will occur in non-coding regions, and they don't alter protein structures at all. If they do occur in a coding region, they may have harmless effects. They may have harmful effects. They may be completely silent and not alter the structure of the protein at all, or they may have some other effect, right? And given that, and given that people are so diverse and so different from each other, it's felt by some that this may be, sort of one of the keys. Again, it's never going to be the whole picture, but it's one of the keys to personalizing treatment. So the SNPs that we're going to focus on today are predominantly in the CYP450 detoxification system, which all of you, I know you're aware of. But again, just a brief review of detoxification in the liver. Phase 1 is the cytochrome P450 enzymes, and that's the first kind of wave of detoxification that prepares things so that they can be removed by the second phase, the phase 2, the conjugation pathways, and eliminated from the body. One thing I do want you to pay particular attention to is the nutrients needed here for phase 1 detoxification, and that includes folic acid because that's going to come back again later. All right, so the Food and Drug Administration in the United States does have some label some indications on the labels for particular pharmacogenomic biomarkers and interactions that they may have with certain medications. Psychiatric medications have the highest number of those biomarkers identified by the FDA. So this is where the product that we use, GeneSight, comes in, and it gives us something called combinatorial pharmacogenomics, which I'll talk more about in a second. This is, again, one of many products on the market, each of which has their strengths and weaknesses, but it is what we use at Loyola, where Dr. Hallers and Dr. Prohaska and I work. We've selected it predominantly because it does have the best evidence base of any commercially available product. However, there's more testing needed, of course. There's always more work to be done, and we are doing our part of that work. It also has the best financial profile for our payer mix. It is covered by some private insurance as well as Medicare and Medicaid, our public insurance programs, and that is the bulk of our payer mix. So what the heck does combinatorial mean? As we know, most medications are not cleared by a single detoxification pathway. The example I give is Valium or diazepam, which is cleared actually by 5 separate pathways in the CYP450 system, and predominantly by 2C19 and 3A4, with minor contributions of the other 3. It also, of course, is metabolized to nordiazepam, temazepam, oxazepam, and all of those have their own specific clearance, which changes the way the medication is, metabolized for any particular patient. But, as we just alluded to, different pathways are more important than others. So if a mutation occurs in a minor pathway, it may not actually be that relevant to your particular medication. A nice graphic representation of this. So this is fluoxetine, and it is metabolized by these 4 CYP450 enzymes that are to the right of the slide, and also interacts with the serotonin transporter gene SLC6A4. So in this particular profile, this person has low activity or decreased activity in 2D6, which is a major player in the detoxification of this medication, and a significant reduction in 2C9, which is the other big one. They also have a reduction in 3A4 and are hypermetabolizers of 2C19. So if you were just to look at 2C19, you might dose this medication higher because they were clearing it faster. If you looked at 3A4, you might just say, you know what, it's probably fine. But the fact of the matter is that the majority of the drug is going through 2D6 and 2C9, and those are both pretty dramatically impaired, right? So again, why are we using this product at our institution? Like I said, it has the best evidence base for psychiatric combinatorial pharmacogenomics. As you can see here, a number of studies, but one of these is the largest pharmacogenomics clinical trial in mental health to date. And that's the GUIDED study, pardon me, which was designed to evaluate the impact of combinatorial pharmacogenomic testing on psychiatric treatment response in patients with major depressive disorder. Sounds lovely, right? It was 1,167 patients at 60 different study sites in both academic and community-based centers. And these were patients with moderate to severe depression who entered failing at least one psychotropic medication, but the vast majority of them had failed more than one. It was a double-blind randomized controlled clinical trial, which seemed a little odd to me when I heard that. And the fact is the patients and the raters are blinded. The clinicians were not. And I'll talk about a little bit more about that in a second. And so basically what they did was they had 2 arms. The treatment-guided arm, all the patients were swabbed at the beginning of the study, right? In the treatment-guided arm, or the guided treatment arm rather, the clinicians were given the report up front, first day. They looked at their report, they made decisions about what they wanted to put their patient on. All psychotropic medications, antidepressants were available to them. They made decisions based on the report. They were reassessed at 4 weeks and then again at 8 weeks. The other half of the patients were just treatment as usual. They went into their psychiatrist's office. They made a decision about what medication to provide. They didn't have access to the genetic report. Again, assessed 4 weeks and 8 weeks. And then at 8 weeks, in that arm, those clinicians were given the report. So having treated the patient for 8 weeks and assessed their response, the clinicians were then given the option of using this report to guide the next step of the treatment. They were again evaluated at 12 weeks and 24 weeks. So this study, when I read this, I was like, this study's kind of designed to fail, right? You have treatment-resistant patients coming in. These are difficult patients to treat. You have a long follow-up. A lot of studies only do 6 weeks, 8 weeks, 4 weeks, just because sometimes that treatment success doesn't sustain itself, right? And another key, these were totally untrained clinicians. The psychiatrists were selected because they either had minimal exposure to this product or none at all. Most of them had none at all. So you have people that you're handing them a report, you're not telling them what to do with it, they don't know what the heck to do with it, and you're just sort of seeing what happens. So really, you wouldn't expect this to work very well. But it did. So this was at 8 weeks. It showed a 50% improvement in remission rates in the group that had used the report to guide treatment, and a 30% improvement in response rates overall. And remission is defined as a HAM-D score less than 7. Response is a decrease in Hamilton D score by at least 50%. Symptom improvement was also pretty significant, clinically significant at 11%, but did not yet reach statistical significance. However, when the patients, and I apologize, this says 12 weeks, it should say 8 weeks. When the patients were switched at 8 weeks these were patients who were then switched based on the report, so to, as they put it, a more genetically congruent medication. And this was particularly impressive, right? So at 8 weeks, from 8 to 24 weeks, we saw 153% improvement in remission, a 71% improvement in response overall, and a 59% improvement in symptom improvement. All of those reached statistical significance. And of the patients that were improving at 8 weeks, those outcomes persisted up to 24 weeks when the study ended. So, to give you a real-world example and make this a little more approachable, this is a case that was used with permission. This is actually one of my residents back home. She's a 29-year-old Caucasian female, really pretty significant history of depression and anxiety, and then would get just terrible adverse events with multiple different medications, including myoclonus, I think with sertraline, if I'm remembering correctly. So this is the report we get from GeneSight. As you can see, it's divided into 3 different columns, or what they like to call bins. The green column are things where there isn't any particular interaction or any significant interaction between the genetics and the metabolism of the medication. So that's called the green bin. You would expect a response as usual. You would expect to use normal doses because it's being cleared as you would expect. And in fact, if you're using a green medication and they're not responding, sometimes that's a diagnostic clue. Like maybe you're not, maybe you're missing some component, or maybe there's some other piece to the puzzle, right? In the yellow column, those are moderate interactions. So there's usually going to have to be some adjustment in dosing, or just you have to maybe increase your dose a little bit more slowly and be a little more mindful of side effects. And then the red column, red does not mean stop here, but you do have to be more mindful with these medications. You can still use them, you just have to be careful, because these are more significant interactions, and these are more prone to side effects. The one exception to that is in these clinical consideration things that you see here at the bottom of the footnotes, there is a number 9, which fortunately doesn't show up on hers, in which the FDA has said that genetic variation is contraindicated. So, as you can see, when we looked at her report, we could start to understand why she had more trouble with some of these medications that she had tried in the past, a lot of which were in the red column, because a lot of medications are in the red column for her. So her psychiatrist, not me, switched her over to desvenlafaxine, which goes by the brand name Pristiq in our country, and that, as you can see, is in the green column. So within about 6 to 8 weeks, she had complete remission of symptoms. She describes this as a life-changing experience. She's still on it. She's feeling great. Things are pretty good. So that was a really nice kind of success story to see live and in person. The other thing you get on this report, there are some what we call pharmacodynamic genes, as opposed to the pharmacokinetic genes, right? And these are the ones that are included are well researched, and so they're just kind of trickling onto the report. We still won't have as many of them as we do the pharmacodynamic genes. The one in particular that is been very useful to us is the SLC6A4 serotonin transporter gene. Basically, if you have the normal form of that, the long form, that is where your selective serotonin reuptake inhibitors can bind and have their activity. And the mutation of that is the short form, which has really nowhere for the drug to bind, and thus doesn't really have any activity. If you have if you're heterogeneous for these You can still use the SSRIs. These people tend not to have as robust a response to the SSRIs, and they tend to take a lot longer. Instead of 2 to 4 weeks, it's 6 to 8. So you can still use them, but you have to be a little bit mindful of that. And I think here's a graphic to show that. So like I said, these are newer. There are fewer of them. They're kind of still forthcoming, and they're still validating some others that are going to be coming. So just to kind of run through, this is the rest of the, you get 4 reports with this particular product, kind of run through the rest of the psychotropics. There's also a report for the ADHD medications, both stimulant and non-stimulant, which also includes the ADR-A2A and COMT genes, which talk about stimulant response in ADHD. There's also an analgesic panel, which looks at both opiate and non-opiate medications and has a pharmacodynamic gene for analgesic response to opiates, which is helpful actually for some of our pain management colleagues. The last report, and this breaks it down by which pathway. All right, so the last report, which is frankly my favorite, is an up-and-coming thing called MTHFR, or methyl tetrahydrofolate reductase, which codes for a protein that methylates folic acid and allows it to be brought into the cell. The issue with that, right, is if you have 2 non-functional copies, 2 mutations of the gene, and are over in the red here, you're really only getting about 20 to 30% of your ambient folic acid that is circulating in your bloodstream, right? Why is that important? Well, as we saw before, folic acid is a precursor in neurotransmitter synthesis. It's an important cofactor in detoxification. It's an important cofactor in many other reactions in the body, right? So if you have all of that circulating in, you're testing blood levels and you're like, oh, folic acid's fine, but you can't get it into the cell where it needs to work, you're really kind of tying your hands, and that can help explain some treatment resistance. There's also some data to suggest that it may be pro-inflammatory, and I've had some very interesting and frankly dramatic results with supplementing L-methylfolate, which is the already methylated form that goes right into the cell without needing transport, in people that have red, that are significantly reduced converters. There's a little bit of controversy in the yellow folks. I've had a number of them that have responded well, but again, it's not the same robust response, but they're still only getting, I think, about 60 to 70% of their circulating folic acid. So can be a pretty big deal. All right, so how do you use this in a practical sense, right? Certainly there are people that say every patient who comes in should get swabbed. When they walk in the door, swab them, see what they've got. Well, okay, maybe that's true. And if this were free, I'd say absolutely, let's do it. Right, but you have multiple factors to consider here, right? There are risk benefits to weigh. One is patient finances. Like I said, for our patients on government assistance, there's zero cost out of pocket. But for our patients that have private insurance, there is a copay. It's fairly reasonable and it's income dependent, but for some people that is a big factor. The other thing is if they come in and they're on a medication that's working and you swab them and it turns out to be one of those red column medications, are you going to change it? Well, no, it's working, right? So is this going to really make a difference? Are patients concerned about, it's my genes? The company does destroy the genetic information or the genetic material after about 2 years, I think, but some patients, it still worries them. So like I said, you have to use your clinical judgment here. So here's what it isn't, and this is, I think, where the controversy comes from in the U.S. People really would like it to be a silver bullet, right? People would really like to run a test and have it come back and it say, oh, you need 60 milligrams of duloxetine and this is going to fix your life. You're going to feel so much better. It just isn't that. It is a way to guide treatment. And what I tell my patients is, this is more than an indicator of what we should use. It's an indicator of what we probably shouldn't use first line. Right? So here are the things that are probably not going to work as well, that may cause more side effects, and so we're going to eliminate those initially, and we're going to look at the things that are more likely to succeed. That, as we all know, psychiatric medication management is often a lot of trial and error, and this cuts down on that. But it's not going to give you the magic answer. It's not going to tell you, oh, you have bipolar disorder, or oh, this is major depression, or oh, you're borderline, whatever. It's not a diagnostic test for a specific illness. And again, it's not an indication to fix what isn't broken. So if they're on something that's working, even if it comes back in the red, keep doing what's doing. Don't reinvent the wheel. Don't, fix something that isn't broken. So the way to disappoint yourself with this test is to have expectations. It's not a magic wand, not a silver bullet. It doesn't make us psychic, much to the disappointment of pretty much everyone. All right, so again, the last thing I want to touch on is, is there a role for our primary care colleagues? And in the U.S., absolutely there is. In our country, about 1 in 10 adults are prescribed an antidepressant medication. Whether they take it or not is a whole other issue. And 75% of those prescriptions are written by a primary care doctor, which for us is either internal medicine or family medicine. So the most efficient place for this testing may in fact be the front line. And we're working on that at some of our local hospitals and at our hospital itself. And again, the Graydon study that we talked about earlier, all of those physicians were gene site naive or very inexperienced. And so it may, with a little bit training, we may even have better results. But to think about, we're kind of tossing, inexperienced people or primary care providers that don't have quite as much clinical background as we do, it may still be, it's maybe not ideal, but it may still be helpful, right? All right, so that is where I'm going to conclude, and I'm going to return to my colleagues here, and we will entertain all of your questions for all 4 talks. Thank you.